Today we have questions from medicine, the ones which are like, the must know, the most important. And if you make, you're not able to recall or make mistake, even one of this, it is very, very important, right? You revise this. All right. So starting with the first one, what drug is used to prevent the painful crisis in sickle cell anemia?
Hydroxyurea.
Hydroxyurea, which prevents the painful crisis in sickle cell anemia. And what is the inheritance for sickle cell anemia?
Autosomal recessive.
C. Remember, sickle, hemophilia C, cystic fibrosis, it's autosomal recessive. Correct. What meningitis has normal glucose?
Viral.
Viral meningitis.
Correct. Remember, viruses like do not eat glucose, so the glucose is going to be normal in viral meningitis. Next one, what is the most important prognostic factor which is used in multiple myeloma?
Albumin and beta-2
microglobulin.
Correct. It's beta-2 microglobulin, very, very important, frequently asked, beta-2 microglobulin and albumin. Okay. And what is that proteasome inhibitor used in multiple myeloma?
Bortezomib.
Zomib is zome, that is proteasome inhibitor. Okay, this was asked in recent FMGE exam as well. What is the most common paraneoplastic syndrome with small cell lung cancer?
Hypercalcemia. SIADH.
It's SIADH, which is the most common. And which are the other paraneoplastic syndromes with small cell?
Lambert-Eaton.
Cushing's. So remember it as small cell lung cancer. So SCL is SIADH, Cushing's, and Lambert-Eaton. Right? So these are the three most important. SIADH is the most common. Next one, dry eyes, dry mouth is going to be what autoimmune disease?
Sjogren's syndrome.
Sjogren's syndrome, right? And what antibodies do you have in Sjogren's? Correct.
Anti-Ro.
Antila, SSA, SSB, right? You should remember it like Sjogren's syndrome A, Sjogren's syndrome B. Anti-Rola is what you have in Sjogren's. Next one, how is TIBC and transferrin saturation affected in iron deficiency anemia?
TIBC is increased, ma'am.
Transferrin saturation decreased.
TIBC increased and
Transferrin is
Decreased.
Very, very important. TIBC is increased and transferrin saturation is decreased. It's because
Yes,
the iron is not available, so transferrin is not saturated. So decreased saturation. TIBC, the iron binding capacity, it is hungry to bind the iron. So that is going to be high. And how about Menzer index?
greater than 13 in iron deficiency and in thalassemia less hota hai 13.
So remember, I for I, it is increased in iron deficiency anemia more than 13. And the formula for Menzer index is?
MCV by RBC.
Menzer starts with M, ends with R. The spelling, so it is MCV divided by RBC count. Right? So that is Menzer index. Next one that we have is what levels are used to diagnose congenital adrenal hyperplasia?
17 hydroxyprogesterone.
Correct. The most common enzyme deficiency is 21 hydroxylase, and in that it is 17 hydroxyprogesterone which is elevated. So that is what we test for, 17 hydroxyprogesterone. Absolutely right. And next one that you have, okay, also tell me that in 21 hydroxylase deficiency, what is present? Hypertension, virilization, both, none?
Virilization.
Correct. I hope you remember the trick. 21, 1 at 1's place is virilization. No 1 at 10's place means no hypertension. So it's virilization without hypertension. Next
In
one,
which video you have taught this?
Sorry?
In which video you have taught this?
We have this in Medicine Extra Edge. I think the 4th one is where you will find it. Pediatrics Extra Edge.
Okay, ma'am. Okay.
Please watch that. It's very, very handy trick that comes to rescue.
Yes, ma'am.
Next, target RBCs are seen in?
Thalassemia.
T for T, very, very important. You get that peripheral smear image. Target RBCs, T for T is thalassemia, important. And how is the RDW in thalassemia?
Increased.
Normal.
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 It is increased in iron deficiency.
Iron
Yeah, remember RDW is red cell distribution with, what varying sizes of RBCs are present. So thalassemia is a genetic defect. All the RBCs are equally affected. So the RDW is normal. But in iron deficiency, some cells small, some cells big, right? You have different sizes. That is why the RDW is high in iron deficiency and normal in thalassemia. Next, ST elevation in lead 1, AVL V5 V6 is what wall am I?
Lateral.
Lateral.
Correct. Lateral. Anterolateral. So that's basically what artery?
Left circumflex.
Left circumflex artery.
Correct. It's a circumflex which goes to the lateral side. So remember, it's circumflex 1 AVL V5 V6. And inferior wall MI is
2 AVF.
2-3 AVF.
And what is the artery affected?
Right coronary.
Right coronary artery. So remember that in this inferior wall MI is where you have, how's the heart rate generally?
Decrease.
Bradycardia.
Generally MI में क्या होता है? Tachycardia हो जाता है, but inferior wall MI में bradycardia होगा because
Bradycardia.
right coronary artery supplies the SA node and also the AV node. So SA node gone, so there's going to be bradycardia. And what's the management for inferior wall MI?
Atropine.
Correct. IV fluids and atropine. Next one, what you have is how are going to be the potassium levels in crash injury or rhabdomyolysis?
Increased.
Hyper.
Tubular necrosis.
Correct. The potassium levels will be high because everything from the cell is coming out. So similar to like tumor lysis syndrome, there's going to be hyperkalemia. How about magnesium phosphorus?
Increased.
Even they are increased. Present in the cell, they come out. And how about calcium?
Decrease.
Decreases.
Right? Hyperphosphatemia, binding calcium, causing hypocalcemia. So remember, there's hyperkalemia, hyperphosphatemia, hyperpachycemia, but hypocalcemia.
Calcium.
Right. Next one, pulsus bispherians. Where do you see pulsus bispherians?
HOCM.
HOCM.
AR. Severe AR.
The previously asked question in one of the FMG exam is what valve pathology generally leads to pulsus?
AR.
Aortic regurgitation. Right? And when I said pulsus bispherians, so there are going to be two peaks. The two peaks are present like both in systole, both diastole, one systole, one diastole.
Systole and diastole.
One systole and one diastole.
One diastole.
It is both systole. Right? Like imagine in aortic regurgitation, what is happening is the left ventricle is pumping, there is some backflow which is coming, and again it is pumping. So this is happening here. जो थोड़ा सा relaxation होता है of the aortic valve के आगे proximal aorta का, then the blood comes back. So pulsus bispherians is going to be in both the peaks in systole. Right? Remember, it is both the peaks in systole. Important. Next one, FBN1 gene mutation is what disease?
Fibrillary.
Remember, FBN is nothing but fibrillin, and that's affected in Marfan's. Tall patient, erectodactyly. How is the lens subluxation in Marfan?
Superior temporal.
Superior lateral.
Fan up and out. So it is up and out, superior-temporal. And heart में क्या होता है Marfan में?
MVP.
Valve prolapse association, very, very important. And then you have aortic dissection.
Aortic dissection.
Right. Affects what aorta? The aortic dissection in Marfan?
Thoracic aorta, descending.
Ascending. It is
Ascending aorta.
It is ascending aorta which is commonly affected. Okay. Next one, what is that neurological condition where there is hypertonia with fasciculations, but the sensory system is intact?
Low element.
Which condition? There's hypertonia with fasciculations.
ALS.
ALS, correct. Because hypertonia is UMN manifestation, fasciculations is LMN manifestation. So both UMN and LMN, right? That's seen in ALS, amyotrophic lateral sclerosis, right? And the sensory system is intact. Bowel, bladder, all that is also intact. Okay, so that is ALS. And what drug do we use in ALS?
Idaboron.
What gene mutation do you have?
SOD1.
Superoxide dismutase. SOD mutation is seen there. Correct. Next one in sarcoidosis. If I ask about what is the stage 2 of sarcoidosis?
Both bilateral lymphadenopathy and the bilateral lymphedema.
Correct. So remember in the sarcoidosis, you have stages. Stage 1 is where it starts with the hilar lymphadenopathy. Whenever in the question you have bilateral hilar lymphadenopathy, think of sarcoidosis always. So first is just the lymph nodes. Second is now going into the lung. That is lymph node plus lung involvement. Now 3 is the lymph node is gone now, only the lung. And then 4 is like the end stage where fibrosis and all of that is coming in. So remember, first is lymph node, then lymph node plus lung. So stage 2 is lymph node plus lung. Next one, urinary metanephrin elevated is what condition? Pheochromocytoma. And what sign do you get in MRI in pheochromocytoma?
Salt and pepper.
Bulb.
MRI pe.
Light bulb sign.
Bulb
Light bulb sign on T2 weighted MRI, right? It shines up. It's very bright on T2 MRI. It is light bulb sign that is seen. And what nuclear scan do you do for pheochromocytoma? MIBG or a PET scan, which is DOPA PET specifically is what you can do. So MIBG and DOPA PET. Okay. Next one that we have is, what is the acid base abnormality in vomiting?
Metabolic alkalosis.
Correct. In vomiting, the acid is going out. So it is metabolic alkalosis. How is going to be pH, bicarbonate, and PCO2?
All
are equal.
Correct. Metabolic ME is same.
Low.
So all the 3 will increase. And how is going to be the chloride level?
Decreased.
Remember, it's hypochloremic metabolic alkalosis, like you read in pyloric stenosis as well. So the chloride will be low. Okay, it is metabolic alkalosis. Next one, what is the drug of choice in stable VTAC? Stable ventricular tachycardia. Correct. Amiodarone. If the patient is unstable, then you would directly go for cardio version. Otherwise, in stable VTAC, it's going to be amiodarone.
मैम वो कार्डियो वर्जन में 2 टाइप है ना, मतलब कौन से इसमें क्या देना है, वो थोड़ा कंफ्यूजन होता है. मतलब कार्डियो वर्जन में मतलब एट्रियल में अलग है और वेंट्रिकुलर में अलग है, ऐसा कुछ.
एट्रियल और वेंट्रिकुलर में अलग है कि या फिर वो मोनोफेजिक और बाइफेजिक वाला पूछ रहे हो?
हाँ, मोनोफेजिक बाइफेजिक.
हाँ, so I think monophasic is not used now. ये शायद recent FMG एग्जाम में भी आया था कि monophasic अभी यूज नहीं करते. It's biphasic which is used. Monophasic में क्या होता है, high energy यूज करते हैं, which is more than 200, so 200 to 360 के इसमें. तो high energy है तो उसमें ज्यादा चांस होता है स्किन बर्न्स वगैरह का. और बाइफेजिक में लोअर एनर्जी है, which is less than 200, 120 to 200, राइट. तो बाइफेजिक में क्या होता है, वो ऑटोमेटिकली एडजस्ट करता है पेशेंट के बॉडी रेजिस्टेंस के हिसाब से, और इसीलिए वो ज्यादा सेफ होता है. सो नाउ व्हाट वी प्रेफर इज बाइफेजिक.
How much energy for biphasic?
For biphasic it is 120 to 200. So remember, like biphasic 2, दोनों numbers में 2 आता है, it is less than 200. Lesser energy, so safer, right? And it automatically adjusts also. So remember, it's biphasic which is used. 120 to 200. More than 200, 200 to 360 is monophasic. Yes, so that is what we prefer now. Okay. Any other query? So we have the mini GT6, which is scheduled for today. Right, I shall make it live today, but I'm only, not sure about the discussion. Aaj ho payega ki nahi. So if the discussion is not happening today, we will do it tomorrow or day after tomorrow. This 10th or 11th. Because tomorrow we also have radiology ke video based questions wala session hai on Prep Ladder YouTube channel. I think morning 11 a.m. So we have that as well. So in case, you want to see those radiology VBQs that can be asked in exam, so you can join for that YouTube live session, and mini GT6 aaj live ho jayegi. So please attempt that mini GT. Okay, very, very important. Right? Okay, any other queries? Yes. Someone is asking, can we use procanamide for VTAC? Yes, we can use procanamide also. Right, we can use lignocaine as well, especially if it is post-MI. Right, so you have amiodarone, procanamide, lignocaine, all of these can be used. Remember, lignocaine is only for ventricular ones, not for supraventricular one.
Ma'am, your rapid revision videos, I have seen one video that is more high yield. So can I watch that now? I haven't watched radio videos till now.
हाँ चलेगा see because majority of the radiology जो होता है ना you have read in an integrated way in medicine, peds, ortho, surgery काफी जो integrated वाला है आपने वहाँ पढ़ा हुआ है so dedicated अगर radiology देखना भी है so then you should focus on the basics, the general part which is not covered anywhere else, you know, like the concept of photoelectric effect, Compton effect, or maybe the contrast media, and then the nuclear medicine and radiotherapy वाला part. बाकी जो systemic वाला है majorly you would have covered, you know, बाकी subjects में.
Okay.
Yes. हाँ, मीनाक्षी सिंह ऐसा लगता है कुछ याद ही नहीं आ रहा है. Seems to lost. ऐसा होता है, right? But when you are in the exam hall, trust me, you will remember everything. Whatever you are feeding into the various folders of your brain, everything will be retrieved. So have that feel. Right now, you will feel like that. Because you know we are clueless कि होने क्या वाला है एग्जाम में, कहाँ से आएगा, क्या आएगा, and that is what makes us feel like, you know, कि कुछ याद नहीं है, या the endless syllabus is what makes us feel like that. So that was for today, guys. Thank you so much for joining in. I'll see you again tomorrow morning with another Medconnect session. And क्या query था? Cardio version versus okay, different pulse types and associations, Ashutosh. We do not have a dedicated video on that. You know, maybe I'll have to work on it. iPad is asking defibrillation or cardio version in VTAC and VFib. Anybody has any opinions on that? What is the concept of cardio version and defibrillation? नहीं. So इसमें क्या होता है? Cardio version and defibrillator. So you know, like in ventricular fibrillation, we are using defibrillator. So when there is no pulse, that is when we use defibrillation. And when the pulse is present, that is where you know you will have this cardio version. So basically, both of them they deliver the electrical energy, right? But when there is no pulse, then you go for defibrillator because it delivers a higher energy. Right? So what happens in cardioversion? It is timed, it is synced, right? And in defibrillation, there is no sync which is there. So it is untimed shock which is given with a higher energy. So when there is no pulse, that is when you use defibrillation. Okay, clear with everyone? So